So what are some of the features of the disease? So for those of you who are not familiar, I'm going to kind of walk through some of the more common features. So they have problems with movement. So they're stiff. It's called rigidity. Okay? They have muscle stiffness. They have instability when they're walking, so they fall down a lot. Okay? They tend to shuffle their gait. The medical word for that is festination. Basically, they just shuffle their feet across the floor. They can have irregular jerk-like movements. That's myoclonus, so a myoclonic jerk. Now, we all do this when we're falling asleep at night sometimes, but this occurs during the waking hours. What's interesting is that for most cases, other than people who start off with Parkinson's disease, they don't have the classic rest tremor. So that pill-rolling tremor that we see in people's hands. And for many doctors, if you don't have a tremor, you don't have Parkinson's, and that's not true. Only about half of patients with Parkinson's disease have a tremor. So even for Parkinson's disease, there's often delays in diagnosis because they don't have a tremor. There are lots of cognitive symptoms, memory symptoms, and most of them are sort of visual, okay? So that they have trouble with visual attention and visual tracking and visual spatial skills. So if you have trouble seeing things, what doctor do you typically go to first? Your eye doctor. And so the eye doctor says, well, I'll fix your glasses. He fixes the glasses, but your vision doesn't get any better. So he fixes the glasses again, and your vision still doesn't get any better. And a smart eye doctor is going to say, well, it's not your eyes, it must be your brain. And so, in fact, the visual systems in the disease are affected very early. They have visual hallucinations. They see things, typically people or animals, and the people tend to be little people, either children or like leprechaunish, dysmorphic kind of people. They're typically not frightening to the patient for the most part. And what's interesting, this occurs very early in the disease. Now, patients with Alzheimer's disease can also hallucinate, but this tends to occur later in the disease. The hallucinations of Lewy body dementia tend to be very well formed. So they can describe everything about the little person or the fuzzy animal, whereas the hallucinations of Alzheimer's disease tend to be ill-formed. So they kind of see something, but they can't really describe what they see. It's kind of off to the side and shadowy. Okay, it doesn't have good features. They can have delusions. Delusions are false beliefs. Most of the delusions are misidentification delusions, so seeing something and thinking it's something else. So there's a famous neurologist called Oliver Sacks. He wrote a book, The Man Who Mistook His Hat for His Wife. Okay? So in other words, what this person did was they looked at the chair and it had a coat and a hat, and he thought that was a person. So that's a misidentification. In particular, a syndrome that's common in Lewy body dementias are called Capgras syndrome. Anybody ever see or read the book Invasion of the Body Snatchers? Anybody ever heard of that one? Yeah. So what Capgras syndrome is a person is replaced by an identical imposter. So you're not you. You're someone who looks just like you, but you're not you. And you can imagine that could be very disturbing to the family, particularly the spouse. They can have fluctuations. These are spontaneous changes in alertness and attention. So they appear drowsy or sleepy during the day. They tend to stare off blankly into space, and their thinking becomes illogical. And these periods sort of wax and wane. They can last from seconds to minutes to hours to days. And then people revert back to where they were before. They often have depression and anxiety. They have a change in their personality, become much more passive or apathetic, lose interest in things around them. They can have irritability. They can be a little more confused at night, like many patients with different forms of dementia. And they have a certain sleep disturbance called a REM sleep disorder. So REM is rapid eye movement. This is your dream sleep. So normally when you dream, your eyes move, but nothing else can. Your body is paralyzed. Okay. In this disorder, people act out their dreams. So they shout, kick, punch. They can have very complex movement. So it can be a sort of an early warning sign. Okay. So how common are these things? So if you look at patients who come in for evaluation and you think about the probability of how likely they are to have Lewy body dementia, if you look at the people in the low probability, those are the people who have Alzheimer's disease, and you can see for the most part they don't have a lot of those symptoms. And the people who are probable are the people who likely have Lewy body dementia, and they have lots of those symptoms. So the symptoms are actually very good at helping us make the diagnosis. Okay? Now you may say, well, if they're so good at making the diagnosis, why do we have such trouble making diagnoses? Because the challenge for all medicine is that you learn things in school, but unless you use it on a regular basis, it's difficult to use. So I could take a test on the Ebola virus, right? So I could tell you I could answer questions about Ebola virus, but I might not recognize it in a patient who has it because I've never seen it before in a patient, okay? So likewise, a doctor could describe these symptoms, but not necessarily recognize them when they're in a patient. All right, so now I'm going to share with you a whole bunch of research data, a lot of it from my lab. The slides look complex. The slides are meant to tell a story. I'm going to tell a story, okay? So I'm not going to describe standard deviations. I'm not going to describe longitudinal trajectories. I'm going to use the pictures to tell a story, okay? So don't be frightened by the complex slides that are coming up, right? So in my opinion, I never change my slides for my audience, right? I can describe my slide to any audience, but I want you to see what I'm talking about. So I'm going to show you the complex pictures. Okay. So one of the things we did was we wanted to try to better understand how we could tell the difference between the different diseases. So we had a study where people came in every year for an evaluation, a longitudinal study. And these people agreed to donate their brain at the end of their life. So we know what they actually had at the end. And what we did, we tried to look at the differences between Parkinson's disease dementia, dementia with Lewy bodies, which are both Lewy body dementias, and Alzheimer's disease. And what we found was that PDD, Parkinson's disease dementia, and DLB, dementia with Lewy bodies, were basically the same disease. Just depend what came first, the chicken or the egg, right? Did they have the movement problem first, or did they have the memory problem first? But otherwise, they had basically the same symptoms. But Parkinson's disease dementia was different than Alzheimer's disease, and dementia with Lewy bodies was different than Alzheimer's disease in exactly the same way. They exactly were different than Alzheimer's disease in exactly the same way. So that tells us that the Lewy body dementias share a lot of common features, and that those features are very different than Alzheimer's disease. And if you know that, then you can use that to try to develop tools to help doctors make better diagnoses. Okay. One of the other things that's important is because the disease is different, right? So people with Lewy body dementia, it tends to be a little bit of a faster disease than Alzheimer's disease. So people die a little bit faster, okay? And so the disease begins at an earlier age, so they die at an earlier age, right? So Alzheimer's disease typically begins in the 80s. Lewy body dementia typically begins in the 70s. But also, when you have the disease, you die faster with Lewy body disease than you do with Alzheimer's disease. And there's also a gender difference. So Lewy body men will die the fastest, and Lewy body women Alzheimer women will die the slowest. Okay? So there's some differences in how the disease affects people, whether you're male or female. We don't really know the reasons for that, but there are important differences. And if you know the differences, then you can investigate the differences and try to understand and help people better. Okay. So we were able to use all of this information and develop some predictors. So we can look at clinical features of people and try to decide whether they likely have Lewy body disease. So for example, if you have a male and you have dementia, you're more likely to have Lewy body disease. If you're a female and have dementia, you're more likely to have Alzheimer's disease. If you have Parkinsonism, you're likely to have Lewy body disease. If you have fluctuations, you're likely to have Lewy body disease. If you hallucinate early on, you're likely to have Lewy body disease. So we can use these things to help us make better diagnoses. One of the other things we're able to do is we do lots of pencil and paper tests, because that's how we characterize people's cognitive abilities. So we give them tests. And we have lots of different types of tests. But when you look at the test, when you're trying to decide what disease someone has, you want to look at the pattern of how people perform. Okay? So this very complex looking slide up there just is how we modeled all the pencil and paper tests. Okay? So at the far end are all the 12 different tests that we used. And we used some very fancy statistical modeling to come up with domains. So we had a verbal memory domain. That's looking at language abilities. We had a visual spatial domain, that's looking at that hand-eye coordination kind of test. And we had a working memory domain, that is the ability to have mental flexibility and use information, okay, like doing math in your head. Okay. But also, we wanted to look at all of the domains together so we can collapse them all together into a general domain. Okay. So we were able to use this very advanced modeling to understand the differences in how different dementias progress over time. Now, if you do that, and you do all this fancy modeling, then all of these fancy testing can be combined to like single scores. And the good thing about a score is you can plot a score on a graph so that you can better understand the disease.